Hello, my friends. I'm Dr. Rachel Storms, and today I want to give you something most people never get in a short doctor's appointment. 3 specific, immediately actionable habits that directly address nighttime urination in adults over 65, including one 10-second physical technique that most people have never been shown, and that can make a meaningful difference starting tonight. Not eventually, tonight. Let me start with the scene I know many of you recognize. It is 3 a.m. You are awake again. Your feet are on the cold floor and you are navigating to the bathroom in the dark, one hand on the wall, hoping you do not trip. And you are thinking, as you have thought many times, that this is just what getting older feels like. I want to challenge that assumption directly. This pattern is common in older adults. But common is not the same as inevitable. And more importantly, common is not the same as safe. Here is the clinical reality I want you to sit with for a moment. Nighttime falls are the leading cause of hip fractures in adults over 65, and a significant proportion of those falls happen during exactly the scenario I just described. Getting up in the dark, in the disoriented first seconds after waking, often with blood pressure that has not yet stabilized to the upright position to make a bathroom trip. Hip fractures in this age group are not simple injuries. Studies consistently report 1-year mortality rates following hip fracture in older adults ranging from 15 to 30% depending on the population. I am not telling you this to frighten you. I am telling you because the problem we are solving today is not just about sleep quality. It is about protecting your physical independence and your safety. That changes the stakes of this conversation. Here is the roadmap for what we are covering. The first habit is about when and how you manage fluid intake, and it goes beyond the simple advice to drink less in the evening that you have probably already tried. The second habit addresses a hidden physiological mechanism that causes fluid pooling in the legs during the day to become urine during the night, something most patients have never been told about. And the third habit, the one I am most excited to share with you, is a 10-second physical technique you can use every time you visit the bathroom that addresses the issue of residual urine, the small amount of urine left in the bladder after you think you have finished, that is responsible for many of the wake-up trips that happen within 1 to 2 hours of going to bed. Let us begin with the first habit. I want to reframe the conversation about fluid management because the standard advice, stop drinking at 6 p.m, is incomplete. In a way that causes many people to try it, find it does not fully work, and conclude that nothing dietary will help them. The issue is not simply volume. It is solute load, timing, and the specific substances you are consuming, not just the amount of water. Here is the physiology that matters. When you lie down, 2 things happen almost simultaneously. First, the venous return from your legs increases because gravity is no longer pulling blood and fluid downward. Second, your cardiac output redistributes, and the kidneys receive a greater proportion of that output than they do when you are upright and active. The kidneys respond to increased perfusion by increasing urine production. This is normal and it happens in everyone. In younger adults with robust antidiuretic hormone production at night, this surge is partially offset by the hormonal signal to conserve water. In older adults, as I have explained in previous videos, that hormonal signal is weaker. The result is that the kidneys are both receiving more blood and operating with less hormonal instruction to slow down, precisely during the hours you are trying to sleep. The practical implication of this physiology is the 3-hour rule, which is more nuanced than simply not drinking after a certain time. The goal is to ensure that the kidneys have processed the bulk of your daily fluid load before you lie down, so that the surge of kidney activity that accompanies the recumbent position does not coincide with significant fluid volume left to process. For most adults over 65, this means front-loading fluid intake into the morning and early afternoon, tapering meaningfully after 2 p.m, and consuming only small sips after 4. The total volume you consume does not change. The distribution changes. Now I want to address something that most physicians do not raise with their patients about medication timing, and I want to be very clear that I am not telling you to change your medications without speaking to your doctor. What I am telling you is that this is a conversation worth having. If you are taking a diuretic medication, whether a thiazide, a loop diuretic, or a blood pressure medication with diuretic properties, and you are taking it in the late afternoon or evening, the diuretic effect of that medication peaks during the night. You are essentially scheduling a period of high urine production to coincide with the hours you are trying to sleep. Many patients, when they discuss medication timing with their physicians and shift a diuretic dose to the morning or early afternoon, experience a dramatic and immediate reduction in nighttime bathroom trips. This is not a minor adjustment. For some patients, it is the single most impactful change in the entire management of their nocturia. If you take a blood pressure pill or a water pill in the evening, please ask your prescribing physician whether that medication could safely be taken earlier in the day. The second habit addresses a mechanism that is responsible for a significant proportion of nighttime urination in older adults and that almost no patient has ever had explained to them before they sit in my office. It is the phenomenon of fluid redistribution from the lower extremities. Here is what happens. Over the course of the day, when most of us are upright and at least partially active, gravity pulls fluid downward into the tissues of the lower legs and ankles. If you have any degree of venous insufficiency, which is extremely common after 65, the veins in your legs do not pump blood back upward quite as efficiently as they once did, and fluid accumulates in the lower leg tissue. You may notice it as mild swelling around the ankles by late afternoon. You may not notice it at all, but it is there. When you lie down, that fluid has nowhere to go except back into circulation. The lymphatic system and venous return mobilize it over the next 1 to 3 hours. It reaches the kidneys. The kidneys process it, and it fills your bladder. This means that a portion of what wakes you up at midnight or 1 in the morning was sitting in your ankles at 6 in the evening. The intervention that addresses this is deliberate, angled leg elevation, performed before you lie down for sleep, during the hours when the fluid can be processed by the kidneys while you are still awake. The specific technique is to lie on a couch or bed and raise your legs above the level of your heart, supported by pillows or a wedge, for a minimum of 20 minutes. The ideal window is between 5 and 7 in the evening. When your legs are elevated above heart level, gravity assists the return of that pooled fluid into central circulation. Your kidneys process it while you are awake. You urinate before bedtime. And when you actually lie down to sleep, there is significantly less reserve fluid in your legs to redistribute. Many patients who implement this single habit report that their first bathroom trip of the night shifts from midnight or 1 to 3 or 4 in the morning, meaning the critical first deep sleep cycle, which is the most restorative, is protected. For patients with significant lower limb swelling, combining daytime compression stockings with the evening elevation session is the most effective approach. The stockings, worn from first thing in the morning until the elevation session in the evening, prevent the fluid from pooling in the first place. The elevation session then mobilizes whatever fluid has accumulated. Together, they dramatically reduce the nocturnal fluid reservoir before you ever lie down. Before I get to the third habit, I want to spend a few minutes on something that affects a significant proportion of the people watching this video, and that operates through a completely different mechanism. I am talking about the role of anxiety and learned bladder behavior in nighttime urination. In many older adults, after months or years of waking to urinate, the brain develops a conditioned association between the transition from deep to light sleep and the urge to void. The bladder does not need to be full. The urge becomes a conditioned response to arousal from sleep rather than a genuine signal of bladder capacity. This is sometimes described clinically as a hypervigilant bladder, and it is reinforced every time the person responds to the urge by immediately getting up, which teaches the bladder that the signal at low volume will always be honored. In men, an enlarged prostate can contribute to this pattern by causing incomplete bladder emptying. In women, weakening of the pelvic floor muscles reduces the structural support of the bladder and urethra. Both of these contribute to the conditioned pattern I described. Understanding that part of what you are experiencing may be a learned bladder response, not just an anatomical inevitability, is important because it means that behavioral interventions, including the technique in the third habit, can genuinely retrain the system over time. The third habit is the one I want you to try tonight, and I want to give you the full explanation so that you understand why it works and perform it correctly. The technique is called double voiding, and it addresses the issue of residual urine. The volume of urine that remains in the bladder after a normal void is considered complete. In a young adult with a strong detrusor muscle and full pelvic floor support, the bladder empties nearly completely with each void. In older adults, a combination of detrusor weakness, reduced bladder neck mobility, and in men, prostate enlargement means that the bladder often retains a meaningful volume of residual urine after voiding. That residual urine is the foundation on which the next fill cycle builds. If you retain 40 or 50 milliliters after each void, your bladder reaches its urgency threshold faster with the next fill. The wake-up that happens 90 minutes after you fell asleep is often not a new accumulation of urine. It is the residual from the last void, plus a modest additional fill reaching the urgency threshold. The double voiding technique addresses this directly. Here is the exact process. When you go to the bathroom before bed and you believe you have finished, do not immediately stand up and leave. Instead, lean your torso forward from the hips so that your upper body is angled toward your knees. Hold that position for 10 seconds while staying relaxed. This forward lean shifts the angle of the bladder base and the urethra in a way that allows gravity and the remaining detrusor contractile force to drain the portion of residual urine that was trapped at the bladder neck by your upright sitting position. After 10 seconds in the forward lean, attempt to void again. Many people find they can produce a meaningful additional volume on the second attempt, volume that would otherwise have remained as residual urine. Stand up slowly with one hand on a support surface to allow blood pressure to stabilize before you walk back to bed. For men specifically, adding a gentle perineal pressure, placing 2 fingers of one hand between the scrotum and the anus, and pressing gently upward and forward during the forward lean can further assist in draining residual urine trapped in the prostatic urethra. This technique is used in formal urological rehabilitation programs and is not widely known outside of specialist settings. For women, the forward lean alone is usually sufficient, but adding a gentle exhale and bearing down with the pelvic floor, similar to the motion of a mild cough, during the second void attempt can improve completeness of emptying. I want to add a brief note on 2 supplements that support the 3 habits we have discussed. Magnesium glycinate, taken in the evening at a dose of 100 to 200 milligrams, supports bladder smooth muscle relaxation and improves sleep architecture, as I described in detail in my video on the nighttime bladder drink. The combination of magnesium's smooth muscle relaxation effect and the complete bladder emptying from double voiding is particularly effective. On the dietary side, reducing sodium at dinner is relevant because high sodium intake drives overnight fluid retention. A simple rule: no added salt at dinner. I also want to name 2 conditions that require medical evaluation if the 3 habits do not produce improvement. The first is sleep apnea. During apnea events, the heart experiences pressure changes that trigger the release of atrial natriuretic peptide, a hormone that directly signals the kidneys to produce urine. The second condition is uncontrolled diabetes. Elevated blood glucose drives osmotic diuresis, meaning the kidneys produce large volumes of urine to clear excess glucose from the blood. If you are waking 4 or more times per night, please ask your physician to check both a sleep study and a fasting glucose. Try habit number 3 tonight. When you go to the bathroom before bed, lean forward, wait 10 seconds, and try again. Then come back to the comments tomorrow and tell me what happened. I read the comments and I respond when I can. Your experience is not just your own. It is information that may help someone else. And if you want to understand one more piece of the puzzle, watch my video on the 7 signs of vitamin B12 deficiency next. It explains how B12 affects the nerve supply to the bladder. Watch that video next.